CDC, our planners, and our presenters wish to disclose they have no financial interest or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, with the exception of Dr. Hampson, and he wishes to disclose that he is a past recipient of a speaker and consultant honorarium from Massimo, Inc., manufacturer of carboxyhemoglobin assessment devices. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use.
Hello, and welcome to Carbon Monoxide Poisoning Prevention Clinical Education. I'm Joe Washington, your moderator for this program, which is originating from the studios of the Centers for Disease Control and Prevention in Atlanta, Georgia. The CDC works with national and state data sources to monitor, evaluate, and present information on carbon monoxide-related illness and death in the United States. It also monitors and evaluates surveillance data on carbon monoxide-related illness and death, and works with state and local agencies to respond to carbon monoxide-related issues. The goal of this program is to enhance recognition and clinical management of carbon monoxide poisoning by clinicians, healthcare providers, and public health officials. Upon successful completion of the program, participants should be able to describe the epidemiology of carbon monoxide poisoning, identify the mechanisms of carbon monoxide toxicity, describe the clinical aspects of carbon monoxide poisoning, identify the symptoms of carbon monoxide poisoning, and explain the treatment of carbon monoxide poisoning. If you'd like to apply for continuing education credit for this webcast, please visit our online system at www.2a.cdc.gov/TCE online and enter course number WD1233. The last day to receive credit for this program is September 20th, 2010. Now, if you'd like to review this program at a later date or share it with a colleague, please note the web address, www.2a.cdc.gov/phtn/webcast/co poison prev. Finally, if you have any questions or comments concerning this webcast, please email us at coinq@cdc.gov. Now, today's webcast addresses the issue of carbon monoxide poisoning. Carbon monoxide is known as the silent killer because it's colorless, odorless, tasteless, and a non-irritating gas. It's produced by burning materials containing carbon, such as gasoline or propane. So carbon monoxide is often associated with fire or smoke, yet it's not detected by smoke alarms, and it can be present even if there is no fire or smoke. Because a small nonpolar carbon monoxide molecule can penetrate through standard drywall, it can pass through dwellings quickly, yet quietly. Carbon monoxide can disperse through separate units of a multifamily complex and, with a density similar to air, distribute itself throughout an enclosed area. You can't see it, smell it, or taste it, but it can make you sick or even kill you. To help us learn more about carbon monoxide poisoning, we're fortunate today to have a distinguished panel of some of the nation's leading experts on this potentially deadly toxicant. First, I'd like to welcome Dr. Neil B. Hampson, Medical Director of the Center for Hyperbaric Medicine at Virginia Mason Medical Center in Seattle, Washington. Dr. Hampson is a member of CDC's National Carbon Monoxide Environmental Public Health Tracking Surveillance Group. Our next guest is Dr. Eric J. Lavonis, Director of Medical Toxicology Hospital Services and Medical Director of Hyperbaric Medicine at Carolinas Medical Center in Charlotte, North Carolina. Dr. Lavonis is also a co-principal investigator of a multi-center CDC carbon monoxide poisoning screening trial. And finally, we welcome Dr. Allison Stock, a toxicologist with the National Center for Environmental Health at the Centers for Disease Control and Prevention. Dr. Stock co-leads the agency's carbon monoxide activity. Welcome to the program. All over the country, you can hear and read stories daily about carbon monoxide poisonings. From Seattle, Washington, after a windstorm. 100 in Northwest stricken by fumes, carbon monoxide blamed for 2 deaths. From southern states after Hurricane Katrina, exhaust from portable generator adds to loss of life. Or from Blacksburg, Virginia, 21 Virginia Tech students get carbon monoxide poisoning from a gas heater leak. Dr. Allison Stock, whose expertise is in the epidemiology and toxicology of carbon monoxide poisoning, will tell us just how widespread this problem really is.
Thank you, Joe. Carbon monoxide is a toxic gas produced from the incomplete oxidation of carbon during combustion. Carbon monoxide poisoning kills more Americans every year than any other acute toxicant. Annually, there are approximately 3,800 deaths from fires or other sources of carbon monoxide. However, 2,400 are intentional or suicides. There are roughly 500 non-fire unintentional deaths a year. Carbon monoxide poisoning stands as the 3rd leading cause of unintentional poisoning death in the United States. In addition, there are at least 50,000 cases of non-fatal acute carbon monoxide poisoning annually. Victims of carbon monoxide poisoning account for thousands of emergency room visits. A recent study by Dr. Hampson extrapolates state rates for emergency department visits for carbon monoxide poisoning to 2005 United States population census. With this updated information, the national average for emergency department visits per year is at approximately 50,000. Even with this revised estimate, however, the impact may still be underestimated, as carbon monoxide poisoning is notorious for being underdiagnosed. Most of the people who attempt suicide by carbon monoxide poisoning are men who poison themselves with automobile exhaust. Sadly, 69% of these attempts are successful. On the bright side, we believe through public education and regulation, we can prevent almost all of the thousands of unintentional carbon monoxide poisonings and deaths that occur each year. One of the difficulties in public education process is reaching those who are actually at high risk, immigrants and minorities. Studies have shown that they are disproportionately affected by carbon monoxide poisoning, especially after power outages, when gasoline-powered electrical generators or gas or charcoal briquettes may be inappropriately used. Men are affected more often than women. Although males and females are equally likely to visit emergency departments for carbon monoxide exposure, males are more than twice as likely to die from carbon monoxide exposure. Males might be exposed to high carbon monoxide levels during high-risk activities such as working in enclosed garages or generators or with power tools. The most impacted age range is 25 to 44 years old. Because of their rapid respiratory rate, infants and children take up carbon monoxide from their environment more quickly than do adults. As with almost any poisoning, the elderly are more vulnerable to the effects of carbon monoxide poisoning. So are people who have chronic heart disease, anemia, and respiratory illness. The death rate from carbon monoxide poisoning is highest among those over 75 years old, and the elderly are at greater risk for adverse neurological outcomes. Animals, such as pets, are also affected. Motor vehicles are still a leading source of carbon monoxide poisoning. Incidents involving cars and trucks can be caused by exposure to exhaust while riding in the back of pickup trucks, which most often impacts children. Obstruction of the tailpipe by snow or other objects, as well as malfunctioning systems. Unintentional carbon monoxide poisoning death rates declined by 80% since the induction of the catalytic converter in 1975 and reduced carbon monoxide emissions. Today, the leading source of non-fire unintentional carbon monoxide poisonings are from home heating sources such as furnaces, water heaters, space heaters, lanterns, stoves, and similar appliances. Smoke inhalation from fires is another important source. So are large and small engines, including boats, power washers, and other gas-powered tools. Carbon monoxide poisonings most often occur in enclosed or semi-enclosed environments where the carbon monoxide can build up. However, poisonings can also happen in the open air. Carbon monoxide-related morbidity and mortality has been reported to arise with the exposure to exhaust from gasoline-powered electrical generators on houseboats, as well as direct exposure to carbon monoxide in the exhaust of a ski boat from either the swim platform or even among persons seated in the stern of the boat. Other boating accidents involving carbon monoxide can result from improper ventilation, backdrafting when operating a boat at a high angle, or even mooring next to a boat while its engine is running. Some poisonings are job-related. Employees may be exposed to carbon monoxide through work with combustion engines or combustible gases, propane-fueled forklifts, and plants producing formaldehyde or coke, at steel foundries or pulp mills, or at the scene of a fire. From the headlines Joe mentioned, however, you can see that carbon monoxide poisoning makes the news most often after a power outage, when loss of electrical power leads to increased use of gasoline-powered generators, kerosene space heaters, charcoal and hibachi grills, propane stoves, and charcoal briquettes for both cooking and heating indoors. The use of these alternative fuels and heating devices may be exacerbated by the use of plastic film or other devices designed to cut air circulation between the inside and outside. The location of the generator is a key factor. Those who suffer carbon monoxide poisoning are most often exposed to a generator kept in a garage, under a deck, near a window, in a shed, in a carport, or in a basement. Except for space heaters, none of those devices should ever be used inside the home, even in the basement or garage, in a camper or tent, or even outside near an open window. Carbon monoxide poisoning is seasonal and can vary by the region of the country. Over 80% of the carbon monoxide deaths are from home heating sources such as gas furnaces. As you would expect, in the northern region of the country, most carbon monoxide poisoning cases occur during the winter heating season, when there is a greater use for furnaces, charcoal briquettes, and generators. People may also warm up their vehicle in their garage before heading out into the weather. In the South, however, power outages most often occur in early autumn, especially August and September during hurricane and thunderstorm season. CDC investigators in Alabama and Texas following Hurricane Katrina in 2005 found 27 incidences of carbon monoxide poisoning, resulting in 78 non-fatal cases and 10 deaths. Nearly all were caused by gasoline-powered generators. A similar study that again included Alabama but added Louisiana and Mississippi found 51 cases, and all but one were due to exhaust from a portable generator. Most occurred within the first week after the hurricane. The use of auxiliary fuels and heating devices when there is a heating fuel shortage is a trend which continues to have an ominous potential for increasing exposure to carbon monoxide and its hazards to health.
Well, now that we understand the source of carbon monoxide poisoning, Dr. Stott, could you explain the process by which carbon monoxide poisoning occurs in the body?
Sure, Joe. Carbon monoxide produces its toxic effects by several important mechanisms. Carbon monoxide enters the body through the lungs, where it binds reversibly to hemoglobin, the principal oxygen-carrying compound in the blood, and in the process, it reduces the blood's oxygen-carrying capacity. It binds tightly to iron sites in hemoglobin with an affinity 200 to 250 times that of oxygen. This enhanced affinity and impaired oxygen binding is referred to as the Haldane effect. When carbon monoxide binds to hemoglobin, it produces carboxyhemoglobin, which inhibits the transport, delivery, and utilization of oxygen. The levels of oxygen normally released to the tissues are decreased. Blood oxygen content is decreased in carbon monoxide poisoning, resulting in tissue hypoxic injury. Carbon monoxide also produces tissue toxicity from its avid binding to intracellular proteins such as myoglobin, the cytochrome A3 complex or cytochrome oxidase of the mitochondrial respiratory chain, and guanylate cyclase. When carbon monoxide binds to myoglobin, it impairs the ability of certain tissues such as the heart to take up oxygen. Myoglobin's affinity for carbon monoxide is approximately 30 to 60 times greater than that for oxygen. Binding of carbon monoxide to cytochrome oxidases disrupts cellular respiration and oxygen utilization in all tissues, including the brain. This binding interferes with the aerobic metabolism and efficient adenosine triphosphate, or ATP, synthesis. Cells respond by switching to anaerobic metabolism, causing a lack of energy supply, lactic acidosis, and eventually cell death. Carbon monoxide causes endothelial cells and platelets to release nitric oxide and the formation of nitric oxide-derived oxidants such as peroxynitrate. This results in endothelial injury and leukocyte sequestration. The end result is lipid peroxidation by neutrophils, degradation of unsaturated fatty acids, which can cause delayed demyelinization in the white matter in the central nervous system, causing cellular swelling and cell and tissue death in certain areas within the brain. The brain damage that occurs after recovery from acute poisoning may result in cognitive defects affecting memory, learning, and movement. These delayed neurological effects may develop over days to weeks following the initial acute poisonings.
Thank you, Dr. Stock, for covering the epidemiology, demographics, and etiology of carbon monoxide poisoning. Now, we now turn to Dr. Lavonis, an emergency room physician, to give us a detailed look at how to diagnose carbon monoxide poisoning in various populations.
Thank you, Joe. The signs and symptoms of carbon monoxide poisoning are variable and nonspecific, so that unfortunately many cases go undiagnosed. One study estimates that the rate of misdiagnosis is as high as 30%. The most common symptoms in victims of carbon monoxide poisoning are headache, dizziness, fatigue, nausea or vomiting, trouble thinking, diarrhea, weakness, and shortness of breath. Unfortunately, these symptoms can also point to viral illness, a benign headache, or gastroenteritis. In fact, food poisoning was found to be the most common misdiagnosis in one study. Some older reports, primarily from autopsy findings, reported that carbon monoxide poisoning causes cherry red discoloration of the skin. In fact, this almost never occurs. Cherry red skin is rarely noted, even in the most severe cases of carbon monoxide poisoning. But there are some red flags. Some red flags that should raise the provider's attention to do further testing for carbon monoxide poisoning. First, if a patient complains of headache, nausea, vomiting, or other common symptoms that could be due to a viral syndrome or carbon monoxide poisoning, but does not have a fever, carbon monoxide poisoning should be considered. With a focused history, exposure to a carbon monoxide source may become apparent. In addition, if a group of patients presents with similar complaints, particularly if no fever is present, carbon monoxide poisoning should be suspected. Severe carbon monoxide poisoning is less difficult to diagnose. In addition to symptoms, patient developed hard signs of neurologic, cardiovascular, and pulmonary dysfunction. For example, in addition to headache and subjective trouble thinking, patients may show confusion, slowed thought processing, irritability, ataxia, seizures, or loss of consciousness. Cardiovascular involvement may result in hypotension, arrhythmias, and even myocardial ischemia or infarction. Respiratory distress might include pulmonary edema, tachypnea, or respiratory arrest. In general, any organ in the body can be affected by carbon monoxide poisoning. Unfortunately, people who are sleeping or intoxicated from drugs or alcohol can die from carbon monoxide poisoning before ever exhibiting symptoms.
So, Dr. Lavonis, with carbon monoxide poisoning being difficult to diagnose, can you give us some insight on diagnostic testing available to rule out or confirm the diagnosis?
I'd be happy to, Joe. The diagnosis of carbon monoxide poisoning is based on a suggestive history and physical findings coupled with confirmatory testing. Patients should be examined for other conditions, including smoke inhalation, trauma, medical illness, or intoxication. Women of childbearing age who are thought to have carbon monoxide poisoning should have a pregnancy test. A neurological examination should include an assessment of cognitive function. For routine clinical use, a mini mental status exam, which takes only 5 to 7 minutes, is adequate. However, there are some special neuropsychological batteries that have been developed to detect the subtle impairment in carbon monoxide poisoning victims that could be missed by routine neurological testing. These tests can be somewhat cumbersome. They require 30 to 45 minutes to perform. They must be administered in a quiet area. The patient must be literate and fluent in English and over age 15. For these reasons, most clinicians simply use a good detailed neurologic examination along with an assessment of cognitive function. Now, appropriate and prompt diagnostic testing is very important. The key to confirming the diagnosis is measuring the patient's carboxyhemoglobin level. It's important to know how much time has elapsed since the patient has left the toxic environment, because that will impact the carboxyhemoglobin level. If the patient has been breathing normal room air for several hours, carboxyhemoglobin testing may be less useful. An elevated carboxyhemoglobin level, which is defined as greater than 2% for non-smokers or greater than 9% for smokers, strongly supports exposure to carbon monoxide poisoning and the diagnosis of carbon monoxide poisoning. An elevated blood carboxyhemoglobin level can advance a case from probable, based on clinical findings, to confirmed. Carbon monoxide levels can be tested either in whole blood or in exhaled air. Blood should be collected in a closed, heparinized container and sent to the lab. If there are several patients from the same environment, often only the most seriously affected need to be tested. Getting lab results can take a significant amount of time, even more so if the lab is outside the hospital. That delay can be detrimental. The most common technology available in hospital laboratories for analyzing the blood is the multiple wavelength spectrophotometer, also known as the co-oximeter. It measures carboxyhemoglobin as a percentage of total hemoglobin. Because a lab co-oximeter can cost $20,000 or more, not all hospital laboratories have them. Most lab co-oximeters can be used to measure arterial blood gases. This leads to the common misconception that carboxyhemoglobin should be measured in arterial blood. This is not necessary and subjects patients to unnecessary risks and the pain associated with arterial puncture. Venous samples are just as good. Venous blood can be placed into a blood gas syringe or any heparin-containing blood sample tube and analyzed on the co-oximeter. The levels in venous and arterial samples are equivalent. If carboxyhemoglobin measurement is unavailable in the treating facility, the patient suspected of having carbon monoxide poisoning may be acutely transferred to a facility where testing is available. It's suggested that a blood sample be drawn first and sent with the patient to the receiving hospital. Recent data reported by Dr. Hampson indicates that human blood stored in vials containing the anticoagulant heparin remains stable. In fact, carboxyhemoglobin levels in whole blood samples with heparin are stable with or without refrigeration for up to 4 weeks, whether the vial is shipped or transported with the patient. While we don't recommend shipping the blood sample because of the time delay, we do recognize that it does happen. The conventional 2-wavelength pulse oximeter is not accurate when carboxyhemoglobin is present. Recently, the Food and Drug Administration approved a 4-wavelength pulse oximeter that solves this problem. In addition to measuring heart rate and oxygen saturation, this new device also measures carboxyhemoglobin levels, all in just a few seconds. We're hoping that this new technology will bring the capability to measure carboxyhemoglobin levels to more hospitals. This would speed diagnosis, reduce the number of misdiagnosed cases, and reduce the need to send out lab samples for analysis. While carboxyhemoglobin levels do confirm the diagnosis of carbon monoxide poisoning, it's very important to note that severity of illness, rather than carboxyhemoglobin levels, should be used to determine the type and intensity of treatment. Carboxyhemoglobin levels do not correlate well with severity of illness, with outcomes, or with response to therapy. It's also important to note that carbon monoxide can be produced endogenously as a byproduct of heme metabolism. It is possible, therefore, for a patient to have an elevated carboxyhemoglobin level as a result of hemolytic anemia or hemolysis due to sickle cell disease. Another approach that is occasionally used to document exposure is measurement of exhaled carbon monoxide with a breath analyzer. Sometimes breath analysis can be difficult since patient cooperation is needed. This may be complicated in the case of young children or patients with altered mental status. Normal exhaled air is 0 to 6 parts per million for non-smokers and up to 70 parts per million of carbon monoxide in the breath of smokers. Measuring environmental air is another consideration. Many fire departments do have the equipment to make these measurements. More than 50 parts per million of carbon monoxide merits further investigation. More than 100 parts per million will likely cause acute symptoms with sufficient exposure time. Now, in a 2005 study in the Journal of the American College of Cardiology, it was found that cardiovascular sequelae of carbon monoxide poisoning were relatively frequent. In that study, 37% of the patients with severe carbon monoxide poisoning experienced a myocardial injury. So in patients with severe carbon monoxide poisoning, it may be important to perform an EKG and measurement of cardiac blood markers. This study also showed that patients with carbon monoxide poisoning who developed cardiac enzyme elevations and/or EKG changes have an increased risk for mortality over the next 10 years, even with aggressive treatment. The exact reason for this is unknown. Unfortunately, right now we do not know which of these patients, if any, need stress testing, echocardiography, or cardiac catheterization. An increase in angina can be seen even with mild elevations of carboxyhemoglobin levels in patients with pre-existing angina. An increase in arrhythmias in patients with coronary artery disease has been noted at carboxyhemoglobin levels as low as 6%. Severe carbon monoxide poisoning can cause myocardial infarction even in patients with normal coronary arteries. Chest radiography is recommended for seriously poisoned patients, especially those who had loss of consciousness or cardiopulmonary signs or symptoms. Brain CT or MRI is also recommended in these cases. These tests may show signs of cerebral infarction secondary to hypoxia or ischemia. To summarize, the diagnosis of carbon monoxide is best made when an elevated carboxyhemoglobin level is documented concurrently with a history, signs, and symptoms suggestive of carbon monoxide poisoning. Now, some other testing, such as a fingerstick blood sugar, head CT, or lumbar puncture may be needed to exclude other causes of altered mental status when the diagnosis of carbon monoxide poisoning is inconclusive.
Thanks, Dr. Lavonis, for walking us through the diagnostic process. We now turn to Dr. Hampson, who will tell us about the options available to treat carbon monoxide poisoning.
Thanks, Joe. As soon as the first responder or medical practitioner evaluating the patient suspects the diagnosis of carbon monoxide poisoning, two very important actions should be taken immediately. One, it is essential to evacuate the area, ventilate the environment, and attempt to determine the source. The patient and anyone else in the vicinity where the patient was exposed to carbon monoxide should be removed from that environment and taken to a safe location. Carbon monoxide uptake ceases as soon as the patient is removed from the contaminated environment. The fire department may be called to handle that job. No form of decontamination is required. Secondly, 100% oxygen by a tight-fitting face mask should be administered. This is fundamental to speeding the elimination of carbon monoxide and improving the delivery of oxygen to affected tissues. Oxygen therapy is safe, inexpensive, and convenient, and it greatly enhances the rate of carbon monoxide elimination. Oxygen therapy should continue until the patient is symptom-free, which is achieved in about 4 to 5 hours for most patients. The carboxyhemoglobin level should go down to the normal range. Repeat carboxyhemoglobin measurements are almost never necessary. For victims of moderate to severe carbon monoxide poisoning, the majority of American experts recommend hyperbaric oxygen therapy. It is estimated that approximately 6% of patients suffering from carbon monoxide poisoning who present to hospital emergency departments are treated with hyperbaric oxygen, or about 1,500 patients per year in the United States. The Undersea and Hyperbaric Medical Society recommends hyperbaric oxygen therapy for carbon monoxide poisoned individuals with the greatest mortality and morbidity risks. Hyperbaric oxygen should be considered when a patient has one or more of the following: a carboxyhemoglobin level of more than 25 to 30%, evidence of cardiac involvement, severe acidosis, transient or prolonged unconsciousness, neurological impairment, or abnormal neuropsychiatric testing. A recently published study suggested that people 36 years old and older are at higher risk for long-term cognitive sequelae, and therefore hyperbaric oxygen therapy should be considered in that group. In cases of milder poisoning, hyperbaric oxygen should be considered if surface pressure oxygen does not resolve symptoms. Clinical studies have proven the efficacy of hyperbaric oxygen in treating carbon monoxide poisoning as assessed by neurocognitive testing. In animal models, studies have demonstrated that hyperbaric oxygen impacts a number of other mechanisms of carbon monoxide toxicity. In addition to enhancing carboxyhemoglobin elimination, these include decreased platelet aggregation and degranulation, decreased neutrophil chemotaxis, decreased rise in nitric oxide levels, clearly demonstrated antioxidant properties, increased dissolved oxygen content in blood, prevention of lipid peroxidation in the brain, and preservation of ATP levels in tissue exposed to carbon monoxide. Normally, a single hyperbaric oxygen treatment is sufficient to render the patient asymptomatic. The optimal number of treatments is not known. A 2002 study in the New England Journal of Medicine demonstrated that 3 hyperbaric oxygen therapy sessions within a 24-hour period reduced the rate of cognitive sequelae when tested both at 6 weeks and even 12 months later, as compared to normal baric oxygen. In practice, most hyperbaric practitioners in the United States administer one treatment and then provide additional treatments if the patient remains symptomatic. Compared to normal baric mask oxygen therapy, hyperbaric oxygen therapy eliminates carbon monoxide from the body more rapidly, improves tissue oxygenation, and reduces the rate of subsequent cognitive dysfunction. The number of patients treated with hyperbaric oxygen therapy for carbon monoxide poisoning has not changed significantly in the United States over the past decade. Because the number of hyperbaric facilities treating the condition has increased, the average number of patients treated per facility has decreased. However, some issues remain. While the majority of experts in this country recommend hyperbaric oxygen therapy for the treatment of severe carbon monoxide poisoning, outside the United States, this treatment remains somewhat controversial. The criteria for defining which patients are most likely to benefit from hyperbaric therapy is still evolving, sometimes making it difficult for practitioners to make the treatment decision. Further complicating the matter is that most hospitals don't have hyperbaric oxygen treatment facilities. As a result, there can be logistical issues related to transfer as well as added expense. Therefore, we would advise practitioners considering hyperbaric oxygen therapy to consult with their local experts in making that decision. Hyperbaric oxygen is the treatment of choice for pregnant women with carbon monoxide poisoning, even if they are less severely poisoned. Hyperbaric oxygen is safe to administer, and international consensus favors it as part of a more aggressive role in treating pregnant women. Carbon monoxide moves slowly across the placenta, thus its elimination from both the mother and the fetus takes roughly twice as long. If mask oxygen is used, the duration should be doubled. It is suspected that the fetus may be more susceptible to carbon monoxide poisoning, and that miscarriage might result from carbon monoxide poisoning. Generally, patients with carbon monoxide poisoning can be released from the hospital after 4 to 6 hours of oxygen therapy if they are neurologically normal, have no more than mild symptoms, and have no other unmet medical or psychiatric needs. However, the long-term outcomes are still uncertain. In one prospective study, 33% of patients not treated with hyperbaric oxygen had cognitive sequelae, and 18% had sequelae despite treatment with hyperbaric oxygen. In addition, 43% of poisoned patients exhibited affective problems 1 year following poisoning. It also appears that cardiac injury at the time of poisoning is associated with an increased risk of mortality over the following 10 years. All discharged patients should be warned of possible delayed neurological complications and given instructions on what to do if these occur. Follow-up should include a repeat medical and neurological examination in 1 or 2 weeks. Most patients, but not all, will resolve to normal. For some, it will take weeks, for others months. but thousands of carbon monoxide poisoned patients will develop lasting signs of brain injury, most commonly cognitive and personality changes, and some may even develop Parkinsonism. Researchers are working to develop antidotes other than hyperbaric oxygen that can prevent brain injury from carbon monoxide poisoning. They are focusing on drugs and chemicals that block the production of nitric oxide, or that interfere with the biological process of apoptosis. Apoptosis is a controlled dying back of undesired cells. It's a natural process. For example, it is through apoptosis that the webbed hands and gill slits that we all had during fetal development go away before we are born. Carbon monoxide poisoning triggers apoptosis in brain cells, and apoptosis inhibitors protect against carbon monoxide poisoning in laboratory animals. Although most of these chemicals are too toxic to use in man, several do show promise. Research is ongoing, and we are hopeful of adding new treatment methods to our arsenal.
Thank you, Dr. Hampson, for summarizing the treatment options for carbon monoxide poisoning and the issues surrounding them. Now, as public health officials and practitioners who see the potentially devastating effects of carbon monoxide poisoning, I'm sure you'd like to know what can be done to prevent this problem. We've asked Dr. Labonis to give us some insights into steps that can be taken to prevent carbon monoxide poisoning.
Thank you, Joe. The vast majority of carbon monoxide poisoning cases are non-fatal. Even when appropriately treated, however, carbon monoxide poisoning may result in significant sequelae. Therefore, prevention is extremely important. Dr. Hampson emphasized that when carbon monoxide poisoning case is confirmed, one of the first courses of action is to find the source and to remove everyone from the environment. That action, along with an active search for secondary cases, is critical to prevention. It is a red flag that signals an emergency that requires immediate action. Since we recognize many of the sources of carbon monoxide poisoning and the time of year when they most often occur in various regions, it makes sense to target public education programs. Storm-related carbon monoxide poisonings are common, predictable, and likely very preventable. Public service messages in local media can be tied to the appropriate season, such as before and during cold weather, when indoor heating is most often used, or in the peak season for storms. TV weather channels and reporters should be educated in advance to include warnings about carbon monoxide exposure risks as storms approach. This is a valuable public service. Radio broadcasts are most effective, especially when the electricity goes out and people are either stranded in cars or using battery-powered radios at home. Sample public service announcements are available on CDC's website. It is essential that these messages be multilingual to reach immigrant and minority communities, as these are the people who most often fall victim to carbon monoxide poisoning during power outages. In addition to news media, electrical utility companies and governmental agencies can help promulgate warnings with regard to carbon monoxide, both when power outages are expected and soon after they occur. When there is a power outage after a storm, most carbon monoxide poisonings occur in the second and third days after the storm. This suggests there is a window of time for effective communications regarding the dangers of carbon monoxide poisoning, even after a storm strikes. Now, there are many simple steps people can take in their own homes to prevent carbon monoxide poisoning. For example, with home appliances, people should have their heating system, water heater, and any other gas, oil, or coal-burning appliances serviced by a qualified technician every year. Service experts should also be called in if an odor from a gas refrigerator's cooling unit is detected. This could mean there's a defect in the cooling unit, which could be giving off carbon monoxide. When purchasing gas equipment, people should only buy equipment carrying the seal of a national testing agency, such as the American Gas Association or Underwriters Laboratories. Appropriate venting of gas appliances in a home, cabin, or camper can help avoid carbon monoxide buildup. Indoor vent pipes should not be perfectly horizontal. They should go up slightly as they go towards the outdoors. This helps prevent carbon monoxide or other gases from leaking if the joints or pipes aren't fitted tightly. Patching of vent pipes with tape, gum, or other products may allow the carbon monoxide to vent out of the system, so only proper and approved patch materials should be used. Chimneys should also be checked or cleaned every year to be sure they're not blocked by debris. People can also avoid carbon monoxide buildup in their cars by having a mechanic check the exhaust system every year. It just takes a small leak in a car's exhaust system to lead to increased carbon monoxide levels inside the car. Changing government regulation is another approach that can have a major impact in carbon monoxide poisoning prevention. As an example of a success story, unintentional carbon monoxide poisoning death rates have declined by 80% since automobiles were required to have a catalytic converter, and carbon monoxide emissions were therefore reduced. Introducing emission control devices to propulsion engines on recreational boats could also help to reduce carbon monoxide concentration in the exhaust, thus reducing the risk of carbon monoxide poisoning. Until that happens, recreational boaters should make certain to turn off the motor before allowing anyone to swim or body surf off a boat. Exposure to the exhaust system while the engine or generator is running can expose a swimmer to carbon monoxide. Now, inexpensive carbon monoxide alarms have been available since 1989. However, they are not currently required in boats, automobiles, or most businesses. Many local governments have started to require them in homes. For example, in my home community of Mecklenburg County, North Carolina, cases of severe carbon monoxide poisoning have been nearly eliminated since the passage of a local health ordinance that requires all homes to have a carbon monoxide alarm. Analysis of cases of carbon monoxide poisoning that occurred after a major ice storm showed that a functioning carbon monoxide alarm warns occupants before carbon monoxide poisoning becomes severe. Now, the plug-in carbon monoxide alarms are the best. However, a battery backup is a must, so the alarm will continue to function when the power is out. Some alarms have a digital readout to show the carbon monoxide level in the room. More advanced alarms actually have detection shutoff switches, so the source of the carbon monoxide is shut down. Carbon monoxide alarm batteries should be checked twice a year. An easy reminder is when changing the clocks during the fall and spring. Batteries should be replaced at least yearly. When a carbon monoxide alarm goes off, residents should leave the area immediately and telephone 911. There is no home therapy for carbon monoxide poisoning. People who have symptoms of carbon monoxide poisoning that do not resolve after a few minutes in fresh air should seek medical attention in an emergency department. With or without regulation, it is important to recommend that people place carbon monoxide alarms in locations where carbon monoxide is produced. Through public education, 93% of homes today have smoke alarms, yet most do not have carbon monoxide alarms. The most important place to keep a carbon monoxide alarm in your home is near the bedrooms, where it can awaken people from sleep if carbon monoxide is in the vicinity. In larger homes, additional alarms should be placed on each level. Because carbon monoxide levels are about the same from floor to ceiling, it is perfectly okay to use a combination smoke and carbon monoxide alarm, or to use a standalone carbon monoxide alarm that plugs into the wall at ankle level. They both do the job well. However, placing the alarm very close to a furnace or garage may lead to false alarms. An ideal location is nearby, somewhere in between the carbon monoxide source and occupied areas of the home. A few states and municipalities have enacted laws and ordinances to prevent carbon monoxide poisoning at hotels, motels, and resorts. New Jersey, for example, requires carbon monoxide alarms to be either placed in each guest unit with an individual or central monitoring system, or in areas adjacent to rooms containing fuel-burning appliances. While smoke alarms were mandated in every U.S. guest room in 1990, carbon monoxide alarms were not. Portable alarms are available for travelers to carry with them to their hotel. Information and education is always more effective when the person you are trying to reach has a need to know. This is why product information at the point of sale is so important. Studies show the most common reason for hazardous use of carbon monoxide creating products is ignorance about carbon monoxide exposure. Yet, if you see the products on the store shelves, it is rare to see an accompanying warning sign about the potential for carbon monoxide poisoning. Labeling on the individual product is desirable. For generators, the label of the underwriter's laboratories indicates the product meets their safety standards. In addition, pictogram warning labels are helpful to reach non-English speakers. Samples of this format are available on the CDC's website. Although people should always read the owner's manual of any appliance and follow its instructions, we know this sometimes does not occur. The issue of language is once again a factor. An even better solution to the issue of carbon monoxide poisoning would be if generators were engineered so they could be used in the wet outdoors, placed far enough from building air intakes, and produce as little carbon monoxide as possible. Having carbon monoxide sensors tied to a cutoff switch would be ideal, but that type of technology poses challenges. Hopefully these changes will occur in the near future, because they do have the potential to help prevent many carbon monoxide poisoning cases. A decline in deaths in this country due to charcoal-related carbon monoxide poisoning was reported by the U.S. Consumer Product Safety Commission when they revised the warning label on charcoal briquettes in 1998.
Thank you, Dr. Lebonis, for bringing to our attention some of the ways that people interested in public health can work towards the prevention of carbon monoxide poisoning. And thank you to our viewing audience for your attention during this webcast. Now, we've attempted to provide you with a solid background on carbon monoxide poisoning. We started with an explanation of it and how it works, and gave you an overview of who most often falls victim to carbon monoxide poisoning. We've also tried to emphasize the importance of being alert to carbon monoxide poisoning symptoms when making a diagnosis and explain some of the latest treatment options. We concluded with some insight into how carbon monoxide poisoning can be prevented. Now, resources for professionals interested in addressing the issue of carbon monoxide poisoning in their community are available online from the Centers for Disease Control. Educational materials, including flyers, prevention guidelines, frequently asked questions, and checklists, may be downloaded from the website. There are also links to professional organizations, documents, journal articles on research, as well as clinical trials information. Resources in your local community are available through a link to the CDC website. Now, if you'd like to review this program at a later date or share it with a colleague, please note the web address, www.cdc.gov/phtn/webcast/CO poison prev. Also, if you'd like to apply for continuing education credit, please visit our online system at www.cdc.gov/TCE online and enter course number WD1233. Finally, I'd like to thank our guests, Drs. Neil Hampson, Eric Lebonis, and Allison Stock, for sharing their informative presentations on today's program. That brings us to the close of Carbon Monoxide Poisoning Prevention Clinical Education. I'm Joe Washington, and it's been my pleasure to be your moderator today. Goodbye.